Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based clinical review on hemophilia in children. This evidence-based session covers pathophysiology, clinical presentation, diagnostic workup, and therapeutic interventions through 15 carefully constructed interactive case studies designed for general pediatricians and pediatric trainees. We will build your ability to recognize hemophilia early, interpret coagulation laboratory results accurately, and select the most appropriate management strategies. Let us get started. Case 1. A 9-month-old male infant presents with progressive swelling and pain in his right knee after falling during crawling. His mother reports excessive bleeding after circumcision at birth and multiple unexplained bruises over the past 2 months. On examination, the knee is warm, swollen, and tender with limited range of motion. Which of the following is the most likely diagnosis? Option A. Idiopathic thrombocytopenic purpura. Option B. Child abuse. Option C. Von Willebrand disease. Option D. Hemophilia A. The correct answer is option D. Hemophilia A. 3 classic features point to this diagnosis. First, excessive bleeding after circumcision is a classic early sign in neonates and is often the first clue to an undiagnosed X-linked coagulation disorder. Second, recurrent unexplained bruising. As infants become mobile during crawling, minor trauma triggers disproportionate bruising due to insufficient factor VIII activity. Third, acute hemarthrosis. Bleeding into joints is the hallmark of hemophilia, producing warmth, swelling, tenderness, and restricted movement in the affected joint. An important clinical pearl: up to 30 to 50% of hemophilia cases arise from new mutations, so a negative family history does not exclude the diagnosis. Idiopathic thrombocytopenic purpura presents with petechiae and mucosal bleeding, not hemarthrosis. Von Willebrand disease causes primarily mucosal bleeding. Case 2. A 3-year-old boy is brought in after a minor fall from a playground structure. He refuses to walk and cries when his left leg is touched. There is no visible bruising. He has a history of prolonged bleeding after dental extractions. Laboratory tests reveal prothrombin time is normal and activated partial thromboplastin time is markedly prolonged. Which of the following is the most likely cause of this presentation? Option A. Von Willebrand disease. Option B. Factor VIII deficiency. Option C. Vitamin K deficiency. Option D. Disseminated intravascular coagulation. The correct answer is option B. Factor VIII deficiency, which is the underlying cause of hemophilia A. The isolated prolonged activated partial thromboplastin time with a normal prothrombin time indicates a defect in the intrinsic coagulation pathway, which is the hallmark laboratory pattern of hemophilia A. The history of prolonged bleeding after dental extractions reflects impaired secondary hemostasis, and the refusal to walk after a minor fall suggests hemarthrosis or deep muscle hematoma. Crucially, the absence of visible bruising does not rule out hemophilia, as deep tissue bleeds into joints and muscles can occur without surface bruising. When an isolated prolonged activated partial thromboplastin time is found, the diagnostic pathway involves a mixing study. If it corrects, a factor deficiency is present. Specific factor assays then identify whether factor VIII is low, confirming hemophilia A, factor IX is low, confirming hemophilia B, or factor XI is low, confirming hemophilia C. Case 3. This is an emergency scenario. A 5-year-old boy with known mild hemophilia A presents to the emergency department. He fell off his bicycle 4 hours ago. He was fully conscious at the scene, but now presents with sudden onset of headache, repeated vomiting, and increasing lethargy. On examination, he appears confused and difficult to arouse. What is the most appropriate next step in management? Option A. Immediate non-contrast head computed tomography. Option B. Administer factor VIII concentrate immediately. Option C. Perform a lumbar puncture to check for subarachnoid hemorrhage. Option D. Observe for 24 hours in the emergency department. The correct answer is option A. Immediate non-contrast head computed tomography. Intracranial hemorrhage is a life-threatening emergency in pediatric hemophilia, even after minor head trauma. The combination of headache, vomiting, and altered consciousness represents the classic triad of raised intracranial pressure and demands immediate imaging. Non-contrast computed tomography is fast, widely available, and detects acute hemorrhage immediately. Do not delay imaging, as early detection is critical for surgical or medical intervention. Factor VIII replacement should be given concurrently or immediately after imaging if intracranial hemorrhage is confirmed. Lumbar puncture is contraindicated due to the risk of herniation if intracranial pressure is raised. Observation alone would represent a dangerous delay in a confirmed or suspected intracranial hemorrhage. The emergency principle is, in a child with hemophilia and head trauma, image first and treat simultaneously. Never wait. Case 4. A previously healthy 6-month-old male infant is found to have a large subdural hematoma on routine cranial ultrasound performed after circumcision. He has no history of trauma. He is otherwise well, with normal feeding and normal developmental milestones. There are no visible bruises or external injuries. His mother denies any family history of bleeding disorders. What is the most likely diagnosis? Option A, vitamin K deficiency bleeding. Option B, child abuse. Option C, severe hemophilia A. Option D, idiopathic thrombocytopenic purpura. The correct answer is option C, severe hemophilia A. Spontaneous intracranial hemorrhage without trauma in a male neonate is a hallmark presentation of undiagnosed severe hemophilia. Factor VIII activity below 1% allows spontaneous bleeding into vulnerable spaces, including the subdural compartment. Circumcision is a classic procedure that unmasks neonatal hemophilia by stressing the coagulation system. Hemophilia severity is classified as follows. Severe means factor VIII activity below 1% with risk of spontaneous bleeds. Moderate means activity 1 to 5% with minor trauma bleeds. Mild means activity 5 to 40% with major trauma or surgery bleeds. Vitamin K deficiency typically presents in the first days to weeks of life, and routine vitamin K prophylaxis at birth makes this unlikely at 6 months. Child abuse must always be considered, but coagulopathy must be excluded first. Idiopathic thrombocytopenic purpura causes mucocutaneous and platelet-type bleeding. Subdural hematoma without thrombocytopenia is atypical. Critically, 30 to 50% of hemophilia cases arise from new mutations, so a negative family history does not exclude the diagnosis. Case 5. A 4-year-old boy is brought to the clinic with a suspected diagnosis of hemophilia. He has had recurrent episodes of spontaneous bleeding since infancy. His mother reports he avoids using his right arm and cries when it is touched. He has no fever and no recent trauma. During physical examination, which of the following findings would most strongly support the diagnosis of hemophilia? Option A, generalized petechiae and purpura on the trunk and extremities. Option B, multiple ecchymoses of varying ages on the shins and forearms. Option C, swollen, red gums with active oozing after brushing teeth. Option D, joint effusion with restricted range of motion and tenderness. The correct answer is option D, joint effusion with restricted range of motion and tenderness. In hemophilic arthropathy, joint effusions are the hallmark finding, most commonly affecting the knees, elbows, and ankles. The child guards the affected limb due to pain and stiffness. On examination, the joint appears warm, swollen, and tender to palpation. Passive movement causes significant pain, while active movement is severely restricted. 3 key signs to look for are warmth and swelling caused by intra-articular blood accumulation, restricted range of motion from pain and joint capsule distension, and a positive bulge sign where a fluid wave confirms effusion on palpation. Generalized petechiae are more characteristic of platelet disorders such as idiopathic thrombocytopenic purpura and are not specific to hemophilia. Multiple ecchymoses are common in hemophilia, but also seen in child abuse and other conditions, so they are not specific enough. Bleeding gums suggest mucosal bleeding, which is typical of von Willebrand disease or platelet dysfunction, not hemophilia. Early detection of hemarthrosis allows timely factor prophylaxis, preventing permanent joint destruction and chronic hemophilic arthropathy. Case 6. A 7-year-old boy with known hemophilia B presents with painful swelling in the right thigh with no history of trauma. He has been less active over the past 2 days and refuses to participate in physical activities. On examination, there is significant localized tenderness over the anterior thigh, firm indurated swelling palpable in the quadriceps region, and decreased strength in the right quadriceps on manual muscle testing. Skin overlying the swelling appears normal in color and temperature. No joint deformity or effusion is noted at the knee. What is the most likely diagnosis? Option A, hemarthrosis of the knee. Option B, quadriceps muscle hematoma. Option C, cellulitis. Option D, deep vein thrombosis. The correct answer is option B, quadriceps muscle hematoma. A 7-year-old boy with hemophilia B presenting with thigh pain, localized swelling, and quadriceps weakness without trauma is a classic picture of a deep muscle hematoma. Muscle bleeds occur most often in the iliopsoas, quadriceps, and gastrocnemius in active children. Unlike joint bleeds, there is no joint deformity, but deep swelling and firmness are present. Pain worsens with passive muscle stretch, which is a key distinguishing sign on examination. Untreated bleeds can cause compartment syndrome, a surgical emergency characterized by rising pressure, paresthesia, and pallor. Chronic muscle hematomas may lead to fibrosis and contracture. An important clinical alert: femoral nerve compression from an iliopsoas hematoma may mimic hip pathology, so always assess hip flexion and femoral nerve sensation. Management requires immediate factor IX replacement to restore clotting function urgently, magnetic resonance imaging to assess extent and compartment involvement, and close monitoring for compartment syndrome using the 4P signs: pressure, pulse, paresthesia, and paralysis. Case 7. A 10-year-old boy with hemophilia A presents with a swollen, tender left elbow. He has been unable to use his arm for 2 days. On examination, the elbow is warm with a positive bulge test and reduced extension. The bulge test is a clinical examination technique to detect joint effusion by applying gentle pressure to one side of the joint and observing fluid movement to the opposite side. What is the most appropriate initial diagnostic step? Option A, point-of-care musculoskeletal ultrasound. Option B, X-ray of the elbow. Option C, magnetic resonance imaging of the elbow. Option D, aspiration of the joint fluid. The correct answer is option A, point-of-care musculoskeletal ultrasound. Musculoskeletal ultrasound is the preferred imaging modality for acute hemarthrosis due to its rapid availability, high sensitivity for joint effusion detection, and safety profile in pediatric patients without radiation exposure. It provides real-time visualization of synovial fluid accumulation and can guide immediate therapeutic decisions. Key clinical benefits include immediate bedside assessment capabilities, high sensitivity for early joint changes, no radiation exposure, making it ideal for children, the ability to detect effusion before radiographic changes appear, and guidance for therapeutic intervention timing. Musculoskeletal ultrasound can detect joint effusion within minutes of presentation, enabling immediate factor replacement therapy to prevent cartilage damage. Magnetic resonance imaging also has excellent sensitivity, but is less immediately available. X-ray has low sensitivity for early joint changes. Computed tomography involves radiation and is not preferred for soft tissue joint assessment. Case 8. A 10-year-old boy is referred to a hematology clinic for evaluation of recurrent spontaneous joint bleeds since infancy. His mother reports that 2 of her brothers had similar bleeding problems. Genetic workup is requested to identify the underlying molecular defect. Laboratory findings: factor VIII activity less than 1%, activated partial thromboplastin time markedly prolonged, prothrombin time normal, platelet count normal. Which of the following best describes the molecular mechanism underlying severe hemophilia A? Option A, point mutations in the F9 gene leading to dysfunctional factor IX protein. Option B, deletions in the von Willebrand factor gene causing reduced factor VIII stability. Option C, inversion of the long arm of the X chromosome disrupting the F8 gene. Option D, autosomal recessive inheritance of a factor XI deficiency. The correct answer is option C, inversion of the long arm of the X chromosome disrupting the F8 gene. Approximately 45% of severe hemophilia A cases result from a large inversion within intron 22 of the F8 gene, which disrupts the gene's promoter region and prevents proper transcription, causing circulating factor VIII activity to drop to less than 1%. The F8 gene is located on the X chromosome, primarily affecting males who carry only one X copy. Carrier females with 2 X chromosomes may show variable expression due to X inactivation. Option A relates to F9 gene mutations, which cause hemophilia B, not hemophilia A. Option B describes von Willebrand factor gene deletions, which do not directly disrupt F8. Option D describes factor XI deficiency, which is autosomal recessive and is hemophilia C, not X-linked. An essential clinical pearl: up to 30 to 50% of new hemophilia A cases arise from new mutations, so genetic testing should always be performed even without a family history. Case 9. A 4-year-old boy with known hemophilia A is evaluated in a hematology clinic. His laboratory workup reveals a normal prothrombin time, but a markedly prolonged activated partial thromboplastin time. His platelet count is normal. There is no history of liver disease or vitamin K deficiency. Why do patients with hemophilia A have a normal prothrombin time, but a prolonged activated partial thromboplastin time? Option A, factor VIII is involved in the extrinsic coagulation pathway. Option B, factor VIII is involved in the intrinsic coagulation pathway. Option C, factor VIII inhibits the common coagulation pathway. Option D, factor VIII activates platelets, which are not measured by prothrombin time or activated partial thromboplastin time. The correct answer is option B. Factor VIII is involved in the intrinsic coagulation pathway. Factor VIII acts as a cofactor in the intrinsic, also called contact activation, pathway, pairing with activated factor IX to activate factor X. The prothrombin time tests the extrinsic pathway, which involves tissue factor and factor VII. Since factor VIII plays no role in the extrinsic pathway, the prothrombin time remains normal in hemophilia A. The activated partial thromboplastin time tests the intrinsic pathway, involving factors 12, 11, 9, and 8. Deficiency of factor VIII directly prolongs the activated partial thromboplastin time. This pattern is critically important to memorize. Isolated prolonged activated partial thromboplastin time with normal prothrombin time should raise suspicion for hemophilia A or B or factor XI deficiency. The thrombin time and platelet count are both normal. Confirming the defect is isolated to the intrinsic pathway. Case 10. A 2-year-old boy is brought to the clinic with a history of prolonged bleeding following circumcision at birth. His mother reports that he bruises easily and had excessive bleeding after a minor fall last month. On examination, he appears well but has multiple ecchymoses on his shins and forearms. Laboratory results show activated partial thromboplastin time markedly prolonged, prothrombin time normal, platelet count normal, bleeding time normal. Which of the following tests is required to confirm the diagnosis of hemophilia A? Option A, prothrombin time. Option B, bleeding time. Option C, thrombin time. Option D, factor VIII activity assay. The correct answer is option D, factor VIII activity assay. A prolonged activated partial thromboplastin time with a normal prothrombin time narrows the defect to the intrinsic pathway. To confirm hemophilia A factor VIII activity assay directly measures the functional level of clotting factor in plasma. Hemophilia severity is classified by factor VIII level. Severe means less than 1% of normal, associated with spontaneous joint and muscle bleeds and life-threatening hemorrhage. Moderate means 1 to 5% of normal, associated with occasional spontaneous bleeds and prolonged bleeding with minor injury. Mild means greater than 5 and less than 40% of normal, associated with bleeding mainly with surgery or major trauma and rare spontaneous bleeds. A mixing study can help distinguish factor deficiency from inhibitor presence, but definitive diagnosis requires direct factor measurement. Prothrombin time, bleeding time, and thrombin time do not measure factor VIII activity and cannot confirm the diagnosis. Case 11. A 5-year-old boy is referred for evaluation of a suspected bleeding disorder. He has a history of prolonged bleeding after dental extractions and recurrent unexplained bruises since infancy. His mother reports no known family history of bleeding disorders. Laboratory results reveal prothrombin time normal, activated partial thromboplastin time mildly prolonged, factor VIII activity level within normal range, platelet count normal. Despite normal factor VIII activity, his bleeding symptoms persist, and his clinical picture is strongly suggestive of a coagulation disorder. What is the most appropriate next diagnostic step? Option A, genetic testing for F8 gene mutations. Option B, repeat factor VIII activity assay in 6 months. Option C, prescribe prophylactic desmopressin. Option D, refer to Child Protection Services. The correct answer is option A, genetic testing for F8 gene mutations. A normal factor VIII activity level does not exclude hemophilia A because some mutations produce a dysfunctional protein that is present in normal amounts. This condition is called cross-reacting material-positive hemophilia, where the factor VIII protein is present but non-functional. Standard antigen assays may appear normal while activity assays are also paradoxically normal, yet the patient bleeds. Genetic testing resolves this diagnostic discrepancy. Genetic testing confirms diagnosis when laboratory results are ambiguous, identifies carrier status in female family members essential for reproductive counseling, predicts inhibitor risk since certain mutations, such as large deletions and nonsense mutations, carry higher inhibitor development risk, and enables prenatal diagnosis through chorionic villus sampling or amniocentesis once the family mutation is known. 2 main approaches exist: Sanger sequencing for known single-gene mutations and next-generation sequencing for whole gene panels covering unknown mutations in complex cases. Case 12. A 6-year-old boy with known mild hemophilia A comes for a routine follow-up. His parents report he has been more active lately, playing soccer and climbing playground equipment. He occasionally complains of knee stiffness in the mornings, but has no obvious swelling or acute pain. His last bleeding episode was 3 months ago after a minor fall. On examination, his knees appear normal with no visible swelling, warmth, or erythema. Range of motion is slightly decreased in the right knee compared to the left. His parents are concerned about potential joint damage despite the absence of recent bleeding episodes. Which imaging modality is most sensitive for detecting early hemophilic arthropathy in this child? Option A, radiographs. Option B, magnetic resonance imaging. Option C, musculoskeletal ultrasound. Option D, computed tomography. The correct answer is option C, musculoskeletal ultrasound. Musculoskeletal ultrasound is the preferred first-line imaging in children for monitoring hemophilic arthropathy. It is radiation-free, portable, and highly sensitive for early hemophilic joint changes before permanent damage occurs. The standardized scoring system for this purpose is called the Hemophilia Early Arthropathy Detection with Ultrasound or HEAD-US scoring system. It assesses synovitis defined as synovial hypertrophy, cartilage integrity, and subchondral bone surface. The scoring range is 0 to 8 per joint, with a higher score indicating greater joint damage. Joints assessed are the knees, ankles, and elbows, totaling 6 joints. What musculoskeletal ultrasound reveals includes joint effusion as the earliest detectable sign, synovial hypertrophy indicating chronic inflammation, cartilage damage shown as thinning of the echogenic cartilage layer, and hemosiderin deposits as hyperechoic foci from repeated microbleeds indicating chronicity. Magnetic resonance imaging has high sensitivity, but is less accessible for routine monitoring. X-ray has low sensitivity and only detects advanced late joint disease. Computed tomography involves radiation and is better suited for bone erosions. Case 13. A 3-year-old boy with known severe hemophilia A is brought to the emergency department with a painful, swollen right knee. The swelling began this morning after he tripped while playing. On examination, the knee is warm, tender, and has limited range of motion. He appears distressed and refuses to bear weight. His parents report no recent factor infusion. What is the first-line treatment for this acute hemarthrosis? Option A, fresh frozen plasma. Option B, recombinant factor VIII concentrate. Option C, cryoprecipitate. Option D, emicizumab. The correct answer is option B, recombinant factor VIII concentrate. In severe hemophilia A, acute joint bleeds require immediate restoration of factor VIII activity. Recombinant factor VIII concentrate provides rapid, safe, and effective hemostasis without the infection risks associated with plasma-derived products. It is the first-line treatment recommended by the World Federation of Hemophilia. Dosing guidelines for acute hemarthrosis are, for a mild joint bleed, target factor level 30 to 50%, dose 15 to 25 international units per kilogram, single dose or repeat in 24 hours. For a moderate joint bleed, target 50 to 70%, dose 25 to 35 international units per kilogram every 12 to 24 hours. For a severe or limb-threatening bleed, target 80 to 100%, dose 40 to 50 international units per kilogram every 8 to 12 hours. For life-threatening intracranial hemorrhage, target greater than 80%, dose 50 international units per kilogram every 8 hours with close monitoring. Fresh frozen plasma contains all clotting factors, but in low concentration with risk of volume overload and transfusion reactions. Cryoprecipitate contains factor VIII, but has inconsistent dosing and higher infection risk. Emicizumab is a subcutaneous bispecific antibody used for prophylaxis in inhibitor patients, not for acute bleeding management. Case 14. A 2-year-old boy is diagnosed with severe hemophilia following spontaneous knee and ankle bleeds. His hematologist is planning a long-term management strategy. His parents ask which approach will best protect his joints as he grows up and becomes more physically active. Which of the following strategies is most effective in preventing long-term joint damage in children with severe hemophilia? Option A, on-demand treatment with factor concentrates for acute bleeds. Option B, regular physical therapy and rehabilitation exercises. Option C, administration of antifibrinolytic agents before high-risk activities. Option D, early prophylactic factor replacement therapy. The correct answer is option D, early prophylactic factor replacement therapy. Continuous prophylaxis with factor VIII or factor IX concentrates, started before age 3, significantly reduces joint bleeds and prevents arthropathy. Studies show that prophylaxis decreases annual joint bleeding rate from approximately 20 bleeds per year to less than 1 per year. It is more effective than episodic on-demand treatment and fundamentally alters the natural history of hemophilia. Key benefits of early prophylaxis include preventing subclinical joint bleeding, maintaining baseline factor levels above 1 to 2%, reducing long-term disability and healthcare costs, and improving quality of life and physical function. Comparing treatment strategies. Early prophylaxis results in less than 1 bleed per year, preserved joint structure, and excellent quality of life with normal activity. On-demand only treatment results in 15 to 20 bleeds per year, progressive arthropathy, and limited mobility restrictions. Physical therapy is an important adjunct but cannot substitute for factor prophylaxis in preventing joint damage. Antifibrinolytic agents are useful for mucosal bleeding, not for preventing hemarthrosis. Case 15. A 12-year-old boy with severe hemophilia A presents with fever and chills developing over 24 hours and worsening joint pain in his right knee despite receiving his scheduled factor VIII concentrate infusion. There is no recent trauma or missed doses. No prior history of treatment failure. He has been on factor replacement therapy for several years. What is the most likely complication? Option A. Allergic reaction to factor concentrate. Option B. Viral infection transmitted by factor concentrate. Option C. Development of neutralizing antibodies, also called inhibitors. Option D. Acute hemarthrosis due to insufficient factor dose. The correct answer is option C. Development of neutralizing antibodies, also called inhibitors. This 12-year-old develops fever, chills, and worsening joint pain despite receiving factor VIII concentrate, which is the classic clinical picture of inhibitor development. His immune system has recognized infused factor VIII as foreign and mounted an antibody response. These neutralizing antibodies called inhibitors bind and destroy the infused factor before it can work. Inhibitors develop in approximately 30 to 35% of severe hemophilia A patients and 5 to 15% of severe hemophilia B patients. They are clinically suspected when standard factor replacement fails to control bleeding. The key diagnostic tool is the Bethesda assay, which measures inhibitor titer in Bethesda units. Low titer is less than 5 Bethesda units and high titer is 5 Bethesda units or more. Management has 3 approaches. For acute bleed control, bypassing agents are used including recombinant activated factor VIIa and activated prothrombin complex concentrate. For long-term eradication, immune tolerance induction uses regular high-dose factor VIII infusions with a success rate of approximately 60 to 80% in high responders. As a novel prophylaxis option, emicizumab is a bispecific antibody mimicking factor VIII function given as a subcutaneous injection with extended dosing intervals. Early inhibitor detection is critical. Suspect inhibitors in any hemophilia patient with unexpected treatment failure or escalating bleeding frequency. Before we conclude, we want to share an exciting opportunity with you. Join Pediatric Case Review on Patreon, your dedicated learning hub for pediatric medicine. All videos in the community are organized by body system, so you can access every lecture neatly arranged and find exactly what you need instantly in one place. Every slide from every lecture is available as high-quality downloadable photos, so you can read, annotate, and practice every question at your own pace, anytime and anywhere. You can also reinforce your clinical knowledge by practicing all case-based multiple-choice questions from every lecture, making it perfect for exam preparation and daily clinical review. If you would like to join, simply comment below on this post, and we will personally message you with all the details. Do not miss this chance to expand your clinical knowledge. And that brings us to the end of today's lecture on hemophilia in children. We hope this lecture deepened your understanding of hemophilia diagnosis, management, and prevention in pediatric patients. We covered 15 comprehensive clinical cases spanning clinical presentation, pathophysiology, coagulation laboratory interpretation, imaging, genetic testing, acute management, prophylaxis, and the important complication of inhibitor development. If you found this lecture valuable, please follow Pediatric Case Review for more evidence-based, case-driven lectures across all pediatric specialties. Have a question or a clinical case to share? Drop it in the comments below. We read and respond to everyone. Stay curious, stay informed, and keep improving patient care.